What is the question here? The question is, describe circle of Willis. Before going into the details of circle of Willis, when I say circle of Willis, what is the first thing that comes into mind? Circle of Willis is a part of cerebral circulation. So, the blood supply to the cerebrum of the brain is derived from circle of Willis. Why it has got special name? The circle of Willis is made up of the branches from anterior cerebral artery, internal carotid artery and the basilar artery. So, different branches from these different main vessels of the blood supply of the brain, they form a circle around an area of brain. So, that is why it has got a name of circle of Willis. And the third point that should come into your mind is, when I say circle of Willis, its prime importance is it acts like a backup system. So, it provides collateral circulation. What does it do? It provides collateral circulation. So, you know the basic points about circle of Willis. Let us now go into the details of where it is located, the anatomy and the clinical significance of circle of Willis. Circle of Willis, as I already told you, is also known as circulus arteriosus, and it is located in the interpeduncular fossa. So, in the image shown here, this is the pons, that is the brainstem, and we have two cerebral peduncles on the lateral aspects of this space. So, I am talking about this space, and this space is the interpeduncular fossa. What is this? It is interpeduncular fossa. Interpeduncular fossa is located in between the cerebral peduncles, and the posterior border is the pontine, that is the pons, and anteriorly there are two bodies known as mammillary bodies. So what are those? Mammillary bodies. In front of the mammillary bodies, you can clearly see the optic chiasma and the optic nerve. So now you know where is cerebral peduncles and interpeduncular fossa located. And this interpeduncular fossa, surrounding this interpeduncular fossa, we do have blood vessels. So the branches from the major blood vessels of the cerebrum, they form a circle around the interpeduncular fossa, giving rise to circle of Willis. Now let us see what are the major branches which are giving rise to circle of Willis. See this. Let us begin from common carotid artery. The common carotid artery takes origin from the aorta, right? So aorta gives rise to two arteries. One is common carotid artery, the other is subclavian artery. So what are the two major arteries arising from the aorta? There is right and right common and left common carotid artery. The common carotid artery gives rise to an internal and external carotid artery. What are the two branches? Internal and external carotid artery. This internal carotid artery is the major supply to the brain. Okay, it goes inside the skull and it supplies the major part of the brain. The internal carotid artery, after entry into the brain, it divides into anterior cerebral artery, posterior communicating artery, and middle cerebral artery. You can see here, this is the internal carotid artery. From here, you can see one branch is ophthalmic artery, which is not important for our discussion. The second branch is posterior communicating artery. This is the second. And you can see clearly the middle cerebral artery is the major branch from the internal carotid artery. And this part is anterior cerebral artery. So this anterior cerebral artery, this posterior communicating artery. Both of these, they take part in formation of circle of Willis. The middle cerebral artery do not take part in formation of circle of Willis. What is your take home? Middle cerebral artery, it do not take part in formation of circle of Willis. Let us go to the subclavian part. The subclavian artery gives rise to right and left vertebral arteries. So vertebral arteries are actually the branches of subclavian artery. The vertebral arteries, you can see here, vertebral arteries, which are branches of subclavian artery, they unite together and their union forms. What is the union of vertebral arteries? It is basilar artery. You can clearly see the basilar artery. So all these are not important for our discussion. The anterior spinal artery, anterior inferior cerebellar artery, the pontine artery, these are all not important. But the end branch of the basilar artery, what is this? This is the posterior cerebral artery. So I am just writing it. Vertebral arteries, they give rise to basilar artery, and from there they form posterior cerebral artery. The posterior cerebral artery communicates with the posterior communicating artery. So now you can clearly see, one side we got basilar artery giving rise to posterior cerebral artery, and the other side we have internal carotid artery giving rise to a posterior communicating artery, and in the front we have anterior cerebral artery. This final loop of anterior cerebral artery is closed by a branch known as, what is this? Anterior communicating artery. Now I am marking the major arteries which are involved in the formation of circle of Willis. Number 1 is anterior communicating artery. Number 2, what is this? The anterior cerebral artery. Number 3, what is this? The posterior communicating artery. Number 4, posterior cerebral artery. And number 5 is basilar artery. So these 5 major arteries, they form a circle. So the circle of Willis is this part. And what is the location? It is located in the interpeduncular fossa. What is the clinical significance of the circle of Willis? What is the need for circle of Willis? As I already told you, it gives redundancy to the cerebral circulation. What is redundancy? Redundancy is otherwise known as the backup. What is that? It gives a backup circulation. As we all know, brain consumes the significant amount of oxygen. Even a minimal stoppage in blood circulation to the brain results in ischemia and death of the brain. So the brain cannot tolerate the lack of oxygen. So circle of Willis provides collateral circulation. So what is that? It provides the collateral circulation to the brain, so that in case of ischemia, the major segment or major part of the brain is spared, because if there is blockage in one part of the circle of Willis, there is a collateral circulation coming from the other part of the circle of Willis. And what is the second clinical significant point? It is aneurysms. The image shown here shows berry aneurysms. You can see the berry aneurysms here. This is the circle of Willis part, and there is an aneurysm coming from the anterior communicating artery and anterior cerebral artery. So this part is actually, this part above this dotted line is anterior circulation. What is this? This is anterior circulation. The remaining part, that is the part which is lying posterior to the dotted lines, the major part of internal carotid artery, posterior communicating artery, posterior cerebral and basilar artery, all these are, they form posterior circulation. They form posterior circulation. Now you see, when I say 40%, I can clearly say intracerebral aneurysms are more common in anterior circulation. What is my first statement? Anterior circulation, intracerebral aneurysms are more common in it. When it comes to posterior circulation, what is that most important point? Even though the posterior circulation aneurysms are few in number, that is the percentage is very low, still they have high risk of rupture. What is that? Still they have high risk of rupture. When it comes to posterior circulation, the basilar artery aneurysms are more common. So what is your take home? Posterior cerebral circulation aneurysms are not common, but the most common among the posterior circulation is basilar artery aneurysms. As the size of the aneurysm increases, what is this? As the size of the aneurysm increases, the chances of rupture of the aneurysm increases. The size of the aneurysm increases, the chances of rupture of aneurysm increases. If the size of the aneurysm is more than 7 mm, if the size of the aneurysm is more than 7 mm, it is wise for a neurosurgeon to operate the patient and repair the aneurysm. The reasons are, if the size is more than 7 mm, there are high chances, that is, these are prone for rupture. They are prone for rupture. So if the size increases, it is better to operate these patients. So these are the few clinical points about aneurysms, that is the intracerebral aneurysms. Let me ask you one single question. There are different parts of circulation of the brain. Why I am referring only to the circle of Willis when I say aneurysms? The reason is, small vessels are taking origin from the major vessels. You can see anterior communicating artery, posterior communicating artery. These are all small blood vessels which are taking origin from the major blood vessels, and these areas are inherently weak areas. What is that? These areas are actually weaker areas. So that is the reason intracranial aneurysms are most commonly seen around the circle of Willis. The next clinical point is subclavian steal syndrome. So in this diagram, you can clearly see the blood vessels taking origin from the major aorta. So this part is aorta, and you can see this is the subclavian artery. The same subclavian artery is these are the, what is this? It is giving rise to common carotid. Common carotid is giving rise to the internal carotid artery, and the subclavian artery, after taking origin from the aorta, it gives rise to a branch known as vertebral artery. As I already told you, this is vertebral artery, this is internal carotid artery, and the two major arteries which are involved in the formation of circle of Willis are ICA and vertebral artery. And you can see a stenotic plaque here. So there is a significant stenosis of the subclavian artery. What happens if there is a significant stenosis? The same subclavian artery, it continues and gives blood supply to the upper limb and thorax. So the upper limb is actually supplied by the branches of the subclavian artery. So it continues as brachial artery, radial and ulnar artery, right? So if there is a stenosis, what happens? There is a decreased blood supply to the limb part. And if there is subclavian stenosis, just concentrate here. The pressure distal to stenosis falls. So as there is a stenosis here, the pressure which is the area pressure which is present distal to the stenosis, it comes down. So when the area is low, actually when you see it on a healthier side, this is the healthier side subclavian artery, there is no stenosis, the blood actually goes up both into the internal carotid artery and the vertebral artery. And what does it do? It gets exchanged in the circle of Willis. From the circle of Willis, it should actually supply the brain. But because of a significant stenosis, what is happening here is the pressure here is coming down, and now there is a reversal of blood flow. Instead of blood flowing from the vertebral artery segment of the aorta towards the brain, the blood is coming from the brain towards the subclavian artery, as if the subclavian artery is stealing. So what is the subclavian artery doing? The subclavian artery is stealing blood from circle of Willis. Now you know the reason why it is stealing, because of decreased blood pressure posterior or distal to the stenosis. This leads to reversal of blood flow. And sometimes the patient may have a syncope or ischemia because the blood is getting stealed from the brain. Reversal of blood flow. So this is subclavian steal syndrome. So when they ask a question about what is circle of Willis, you need to mention its definition, its location, what are the major branches of cerebral arteries which are aiding in formation of circle of Willis, and its clinical significance, that is the aneurysms part, and what is subclavian steal syndrome. The nerve fibers originating from the brain towards the spinal cord, they are organized into both ascending and descending tracts. When I say ascending tracts are mainly concerned with carrying sensory stimulus, whereas descending tracts are concerned with the motor activity. So we'll call it as motor pathways predominantly. These motor pathways are divided into both pyramidal and extrapyramidal tracts. When I say a pyramidal tract, the tracts that decussate in the pyramids of the medulla oblongata. So any descending tract which is passing through the medullary pyramids. So these tracts are known as pyramidal tracts. What are the examples for pyramidal tracts? Corticospinal tracts and corticobulbar tracts. Let's try to understand basic difference between this corticospinal and corticobulbar tracts. Corticospinal tracts, they arise from the cerebral cortex, mainly from primary motor cortex areas, that is area number 4 and 6. Whereas corticobulbar tracts, they also arise from the cerebral cortex, mainly they arise from the accessory motor cortex. After the origin, the corticospinal tracts, they pass through, focus here, an area called internal capsule. So through that, they pass through the midbrain, pons, and in the medulla, they decussate. So they divide in the medullary pyramids. So at the level of medullary pyramids, 80% of the corticospinal tracts, they are called lateral corticospinal tracts because they are decussating at the level of the pyramids. But approximately 20% of the tracts called anterior corticospinal tracts, they decussate not at the level of the pyramids but in the spinal cord segment. So your take home is, of the total 100% of the corticospinal tracts, 100% will decussate, but the level of decussation differs. When it comes to lateral corticospinal tract, which comprise 80% of the total corticospinal tract, they decussate at the level of medullary pyramids, whereas anterior corticospinal tract, which comprise 20%, they decussate at the level of the spinal cord. So what is the primary function of these corticospinal tracts? They help in voluntary motor activity of the body. That is, both the limbs and the axial musculature, the voluntary activity is controlled by the corticospinal tract. Let's quickly shift on to the corticobulbar tracts. Corticobulbar tracts, they also arise from the cerebral cortex, but they are not entering into the spinal cord segment. They stop at the level of the brainstem. The reason is the lower motor neurons of this corticobulbar system arises from the brainstem, and it is predominantly innervating the cranial nerves. So the upper motor neurons from the corticobulbar tract are going out to the cranial nerves. So that is the reason they do not exit in the spinal cord, they exit from the brainstem. Their main function is they control the voluntary motor activities of the face, okay, head and neck musculature. So with this basic knowledge about the pyramidal tracts, let us quickly jump on to what are the extrapyramidal tracts. As already said, pyramidal tracts are arising from the cerebral cortex. These extrapyramidal tracts, they arise from the brainstem. From there, they enter into the spinal cord. When it comes to decussation or crossing to the opposite side, the vestibulospinal and the reticulospinal tracts, they both do not decussate, whereas the rubrospinal and tectospinal tracts, they decussate, that is, they have a contralateral innervation. So what are the four types of extrapyramidal tracts present? One is vestibulospinal, reticulospinal, both are ipsilateral, whereas rubrospinal and tectospinal, which are the other two examples, they are contralateral. Let us now see the origin of these extrapyramidal tracts. We'll begin with vestibulospinal. Vestibulo, that means it arises from the vestibular nuclei. There are two types of fibers, medial vestibulospinal tracts and lateral vestibulospinal tracts. And what is the main function of this vestibulospinal tracts? The fibers in this pathway, They help in controlling the balance and posture of the anti-gravity muscles. What are the anti-gravity muscles? They are flexors of the upper arm and extensors of the lower arm. So the main function of vestibulospinal tract is it is involved in controlling the balance and posture of anti-gravity muscles. Let's now discuss about the reticulospinal tracts. Reticulo, that means it arises from the reticular system. There are two kinds again, medial reticulospinal and lateral reticulospinal. The medial reticulospinal arises from the pontine system, that is pons, whereas the lateral reticulosystem arises from the medulla. The main function of the medial reticulospinal system is it facilitates, that is, it helps in promoting voluntary movements, and also it increases tone of the muscle. Try to remember this. This is very important. Whereas the lateral reticulospinal system, which is arising from the medulla, it does not promote voluntary movements. It actually inhibits the voluntary movements of the body. And also it reduces the tone of the muscle. Now let's quickly discuss the rubrospinal tract. When I say rubro, it arises from the red nucleus which is present in the midbrain. And now you see what is the function of this rubrospinal tract. The function is unclear, but some standard textbooks, they mentioned that it has a role in maintaining the control of hand movements. So the fine control of hand movements is actually regulated by the rubrospinal tracts. But it is always the exact function of rubrospinal tract is unclear. The last type of extrapyramidal tract is tectospinal tracts, and they arise from the superior colliculus of the midbrain. The tectospinal tracts, they coordinate the movement of the head in relation to the vision stimuli. Superior colliculus is involved in the visual system. So the tectospinal tract, they coordinate the movements of the head in relation to the vision stimuli. Now let's make a note of the basic differences structurally and functionally, and also the disease pattern of pyramidal and extrapyramidal tracts. The pyramidal tracts, they control fine movement, as I already told you, and also the voluntary movement of the body. Extrapyramidal tracts are involved in involuntary movements of the body, and they help in maintaining the posture and also the proprioception. They also maintain reflexes of the body, mainly the stretch reflexes. In any lesion of the pyramidal tract, the distal muscles of the body are involved, and also the anti-gravity muscles are predominantly affected. When it comes to extrapyramidal tract injury, mainly the proximal and axial musculature is involved. And the type of rigidity observed with pyramidal tract injury is clasp knife rigidity. You will also see clonus in these cases. The type of rigidity observed with extrapyramidal tracts is lead pipe rigidity or cogwheel rigidity. When it comes to gait, spastic gait is seen in cases of pyramidal tracts. Shuffling gait is seen in cases of extrapyramidal tract. Extensor plantar reflex, that is the Babinski reflex, it is positive in cases of pyramidal tract lesion. It is normal or negative in cases of extrapyramidal disease. When you look at superficial reflexes are affected. That means they are absent in case of pyramidal tract disease. They are not affected. That means the superficial reflexes are present in case of extrapyramidal disease. So what are the extrapyramidal diseases? The classic example is Parkinsonism. There are other examples for extrapyramidal tract disease like the chorea, where you see dancing movements, hemibalismus, you will see violent movements of the upper limb, athetosis, tardive dyskinesia, and dystonia. This is the list of extrapyramidal diseases which are commonly seen in the clinical practice. So in this video, I'll be discussing about the origin, course and distribution, the branches, and the clinical significance of facial nerve. So to begin with, the facial nerve is its seventh pair of cranial nerves, and it's a mixed nerve. That is, it is both motor and sensory. So when I say it's both motor and sensory, it should have two roots. That is, both the motor root and the sensory root. And from where do they arise? They arise from the ventral aspect of the brain stem. Okay, that too from the, as you can see, this is the midbrain, this is the pons, and this is the medulla. Okay, so we have pons, and on the lower border of the pons you can see both the motor root and the sensory root taking origin. So what do we have? We have both motor root and sensory root taking origin, and it is coming out from the ventral aspect of the brainstem, because only nerve which arises from dorsal aspect is fourth cranial nerve. Rest all of the cranial nerves, they take origin from the ventral aspect of the brainstem. So it arises from the ventral aspect of the brainstem from the lower border of the pons. Okay, and this groove which is located here is opposite, because around the brainstem we have cerebellar peduncles also, right? So from the cerebellar peduncle we have an olive and inferior cerebellar peduncle areas. So from these areas it is lying opposite to it. So if you want to remember, it's well and good, or else you can just write that it arises from a groove in the lower border of the pons from the brainstem, that to the ventral aspect, and we all know that it's a mixed nerve. So that's the reason we have both motor and sensory root. So let's see, after taking origin, what is its course and where it is getting distributed. So the main trunk, okay, arising from the motor nucleus, it takes a turn, okay, and this produces a facial colliculus. Okay, and this turn, it's a major root. The main trunk or the motor root, it enters into the external auditory meatus. Okay, and it is accompanied by this is actually not external, it enters into internal auditory meatus, and it is accompanied by a sensory root arising from the superior salivatory nucleus. And these two, okay, the smaller one is known as nervus intermedius of Vrisberg. It's a different name. Okay, along with that we also have a vestibular, cochlear, and labyrinthal. These are all pontine areas. So when you have a clinical stuff called cerebello pontine angle tumors, then you realize why all these are involved, both the sensory and motor root of the facial nerve, and also we have the eighth nerve which is taking origin from here. Okay, so after taking origin, the main trunk, okay, at the lateral end of the meatus, they both unite together, okay, and they form the trunk of the facial canal, and from here it runs above the bony labyrinthine. Okay, it runs above the bony labyrinthine of internal ear, and it bends posteriorly in the medial wall of the middle ear, and this forms a genu of facial nerve. What is it? It's a genu of facial nerve, and from here it runs posteriorly in the middle ear medial wall below the lateral semicircular canal, and finally the nerve turns 90 degrees and runs in the posterior wall of the middle ear till it reaches the stylomastoid foramen at the base, and from here it leaves the cranial cavity. Okay, and after leaving the cranial cavity, it runs anterolaterally to enter the parotid gland, and it divides into the terminal branches. So the origin you understood, and after taking an exit from the cranial cavity, it runs anterolaterally and it enters on to this is like a parotid gland, and it divides into like a crow foot, it divides into 5 facial branches. The middle pathway is a bit tricky. and it is very tough to remember even with the image. So that's the reason, just draw this image when they ask about course and distribution. We all know it is where it is taking origin and where it is ending. In the middle part, okay, it runs in the internal ear, we all know, and it runs in the internal ear, that too from the bony labyrinth and above the bony labyrinth of internal ear, and it forms a genu of facial nerve. Okay, and at the stylomastoid foramen it takes an exit at the base. Okay, it leaves the cranial cavity. So just remember these 2 points: genu of facial nerve, the stylomastoid foramen, and in the middle ear we all know that it gives a branch called chorda tympani, and also nerve to stapedius. So that's the reason when we do a stapedial reflex test, we are not testing 8th nerve, we are actually testing the 7th nerve. And we all know that even the facial nerve also has a sympathetic. Okay, so we have sympathetic and parasympathetic. Sorry, it has a parasympathetic support. The other name for sympathetic is lumbosacral plexus. The other name for parasympathetic is craniosacral. So what are the cranial nerves which are involved? There are 2, 7, 9, 10. Okay, so when I say 7th cranial nerve, it is mainly through the lingual nerve, and it has a parasympathetic supply to the submandibular gland and the sublingual gland. Okay, so yes, the facial nerve also has parasympathetic supply. So yes, it's a sensory nerve, yes, it's a motor nerve, it is also a parasympathetic nerve. So what is motor? It is supplying the facial muscles. What is sensory? Sensory is not sensations of the face, because the sensations of the face are actually carried by, okay, the sensations of the face are actually carried by the trigeminal nerve. It is taste sensations from in front of the sulcus limitans. We have anterior 2/3 of the tongue. Okay, so the posterior 1/3 of the tongue, the taste sensation are carried with the help of glossopharyngeal nerve, and the base of the tongue with the help of the vagus. Okay, in the tongue part we already discussed that. So the taste sensations are carried by facial nerve. It's not the facial sensations, but the facial muscles are supplied by the facial nerve. So this concludes the course, distribution, origin, and the innervation. Okay, innervation is, you all know, the motor, sensory, and the autonomic. Motor facial muscles, sensory anterior 2/3 of the tongue, and the autonomic is submandibular and sublingual glands. It's as simple as that. So the next part is, what are the branches? Okay, so if you know the branches, your job is more easy. Okay, so we have a greater petrosal nerve with the help of the image, which goes to the pterygopalatine ganglion. Okay, and this is a secretory motor too. Yes, even the lacrimal glands, nasal glands, and the palatal gland, they are also getting parasympathetic innervation with the help of a greater petrosal nerve from the facial nerve. We also have a lesser petrosal nerve, which is supplying to the otic ganglion. And next we have nerve to stapedius, okay, which supplies the stapedius muscle and which decreases sound intensity whenever there are large amplitudes of the sound, and we test this with the help of stapedius reflex. We also have a chorda tympani nerve, which unites with the lingual nerve, okay, and it carries, very importantly, the taste fibers to the anterior 2/3 of the tongue, and also it has a preganglionic supply to the parasympathetic fibers of the submandibular and sublingual glands. And later on we do have a post-auricular nerve, which supplies the posterior muscles like occipitalis and posterior auricular muscles, which are vestigial in humans. Next we have nerve to posterior belly of digastric and stylohyoid muscles along with the facial muscles. They also supply posterior belly of digastric and stylohyoid muscles. And we have terminal branches which supplies the muscles of facial expression, what I'm talking about, the temporal, zygomatic, buccal, mandibular, and cervical. So this will conclude our discussion on the branches of the facial nerve. Next we have clinical significance. Simple. So when I say facial nerve, if there is a loss of if there is any damage to the facial nerve, okay, so there are two entities. One is UMN, that is upper motor nuclear facial nerve palsy, and we also have lower LMN facial palsy. So what is the difference between UMN and LMN facial palsy? Is not important, but let me add some insights here. So we have neurons traveling from the cerebellar cortex to the motor nucleus of the cranial nerve 7, which is located in the pons. We have two sets of neurons. One is an ipsilateral set, which is actually supplying the upper half of the face, okay, and we have a contralateral segment which is actually supplying like the whole segment of the opposite body. Similarly, we have an ipsilateral segment which is supplying upper half of the face, okay, and we have a contralateral which is supplying the overall. So what is your take home when I say this? You need to understand one important thing. When it comes to the upper motor neuron innervation of the forehead, it has bilateral innervation. That is, the fibers are coming from the ipsilateral half and also from the contralateral half. Okay, so the contralateral part supplies both of the things. So it has a bilateral innervation, but that is not the case with the lower half of the face. The lower half of the face only has contralateral innervation. So that's the reason, let us say, if there is any lesion to the UMN, okay, upper motor neuron, if there is any upper motor neuron lesion, so this fibers to the upper part are lost, but this upper half of the face, it still has innervation from the contralateral side, okay. So what you need to understand, one thing is, see, one more thing, these fibers, they decussate. So that's the reason you will see a loss of sensation on the opposite half of the face, because the same side it is preserved, but the lower part is lost. So you take an example of stroke. In stroke, the paralysis of the inferior half of face, which occurs contralateral to the side of lesion, is seen because of the crossing of the fibers. Whereas you take an example of Bell's palsy, which is complete damage. So irrespective of the innervation, the damage is on the same side. So you will see the ipsilateral loss of facial sensations on the lateral half. So lateral half, ipsilateral, is LMN type of element, that is lower motor nuclear is getting damaged, right? LMN type of facial nerve paralysis. Contralateral, not lateral half, only lower 1/4. Contralateral, only the lower 1/4 is the UMN, that is upper motor nuclear region facial nerve paralysis. Simple, logic is simple. And yes, how to test these clinically? You might have seen patients with paralysis and stroke. They have only what we call deviation of the mouth. Okay, deviation of the mouth will be to the normal side. Okay, deviation of mouth in both the situations is to the normal side because of normal pulling of the fibers this side, okay, because the facial muscles are active, but these are not active. So there will be like the drooping of saliva here, okay, on the same side, drooping of saliva, on the opposite side there is a deviation of the mouth. Similarly, how to test it? The eyebrows are normal, okay, so that's the reason, not eyebrows, the forehead is normal. So when you ask the patient to close both the eyes, in case of what we call the lower motor nuclear nerve palsy, we have a phenomenon called Bell's phenomenon. And what happens in this Bell's phenomenon, when a person is trying to close both of his eyes, because of the involvement of orbicularis oculi. Okay, the involved side he cannot close the eye, so that's the reason in that involved side there is the eyeball tries to turn up, but the eyelids they do not close. This is known as Bell's phenomena, seen in Bell's palsy. That is not seen in case of UMN type of lesions. And when you ask the patient to frown, he can elevate both of his eyebrows, but that is not the case. On the involved side, you will see loss of the wrinkles on the face, okay, or the forehead. So this is the basic difference. Now with this understanding, you know what happens in LMN palsy, because the classic example of LMN palsy is Bell's palsy. It's an idiopathic condition where there is no reason and there is a facial paralysis, okay, and it is acute in onset, and whenever patient tries to close his eyes, he is unable to do so because of the involvement of the facial nerves, and you will see wide open palpebral fissure, high chances of eye infections and drying, and when he attempts to close, the eyeball turns up, giving that Bell's phenomenon. And on the inward side there is loss of wrinkles on the forehead, and because of that face becomes asymmetrical, and there will be what we call deviation of angle of mouth to the opposite side, that is the normal side, whereas on the involved side there will be a drooping of the angle of mouth leading to drooping of saliva from that side. So because of this drooping, the nasolabial fold which is present on the normal side is absent here. So these are all the features of the Bell's phenomenon. So how do you treat this case of Bell's phenomenon? Yes, we need to reassure the patient, and the patient might have an associated ear pain, okay, so we have to give analgesics in these cases, and you need to take care of the eye because it is wide palpebral fissure. Many of will forget, but you have to pad the eye so that there will not be dryness of the eye leading to keratitis, and some physiotherapy or massage of the facial muscles might help. Okay, if the patient reports within 1 week, in case of Bell's palsy, you can give a prednisolone dosage both in the morning and evening for 5 days. Okay, so you have to see the patient again after 5 days, and if you see any paralysis, so if there is any residual disease at the 5th day of follow-up, what we do, if paralysis is like it's not complete, it's incomplete, or the patient is recovering slowly, anyway when you give prednisolone dosages, you have to taper the dosages. But if the paralysis is complete, if no response, you have to continue the same dosage for another 10 days and you have to taper it for the next 5 days. So beyond that, if it is not responding, the prognosis is poor. But usually Bell's palsy cases, if there is no other cause, if it's an idiopathic one, it responds well to the prednisolone therapy. And there are surgical treatments also, okay, because some say that one school of thought is Bell's palsy is because of the compression of the nerve, okay, which compromises the microcirculation of the facial nerve, and if you do nerve decompression, okay, in the areas where there is pressure on the facial nerve, that might produce some improvement in the symptoms. So this is Bell's palsy. So we are done with the origin, course, distribution, branches, innervation, and the clinical importance of the facial nerve. Now let us look at the previous year repeats. So outline, anatomy, mentioning its clinical significance. Hope you can answer this easily. Explain the origin, yes, the course of facial nerve, and describe its components, yes, and also the distribution, and what is Bell's palsy, and give the anatomical reasons for presenting signs. So now you know the difference between UMN and LMN, why Bell's palsy has all this phenomenon, and enumerate the branches of facial nerve. You have a beautiful diagram there, and you have to write a brief note on Bell's palsy. So this will conclude our discussion on the facial nerve. So let us discuss how the sensations are carried in the body, like the touch, pressure, vibration, and temperature sensations. So what is their pathway and all we'll be discussing in this video. So the most important thing here is from the sensory pathways and ascending tracks, there are not many repeats in the exam, okay, except one question was there long back. So while I'm teaching this topic, I'll be telling you like which can be a potential question in the future, okay. So meanwhile, try to follow the pathway. We are done with the descending tracks, which is more important, that is the pyramidal tracks and extra pyramidal tracks, which was asked in 2018 exam. And this can be a potential question. Let's see the sensory pathways and ascending tracks. Classification wise, you need to remember two things, okay. For exam point of view, there are conscious tracks and also unconscious tracks. So with the consciousness, there are some tracks which will be carrying the sensations. For example, there are two pathways here. One is dorsal column medial lemniscal pathway, very important, and the other is anterolateral system. Okay, anterolateral system, we have spinothalamic tracts in this. There is an unconscious pathway, okay, which is made up of spinocerebellar tracts. Okay, so most of the textbooks, when they say sensory tracts, they'll only mention the conscious tracts. Okay, so this is an extra addition for you. There are some unconscious tracts also, that is the spinocerebellar tracts. So what is sensory pathway? It's a neural pathway which carries sensory information from the peripheral nerves. Okay, and where does it relate? The sensations are relayed in area called post-central gyrus. We all know pre-central gyrus is motor area, but post-central gyrus is a sensory area. So we got three tracks. One is dorsal column medial lemniscal pathway. The other was anterolateral system, and the third track was the spinocerebellar tracks. So we'll discuss three of these tracks, their pathways, and at the end I'll conclude with what happens if there is a defect in each of these systems. Okay, so let us look at the dorsal column medial lemniscal pathway. In all these pathways, what we have is three order neurons. That means starting from first order, entering into the second order, and later on to third order neurons. So there are three order of neurons or layer of neurons we have, okay, the relaying pathway. So what are the sensations which are called carried by dorsal column lemniscal pathway? The sensations which are carried here are tactile, that is fine touch sensation, vibration, and very important proprioception. So the three sensations which are carried by the dorsal column medial lemniscus pathway are fine touch, vibration, and proprioception. So where it is arising, let us see the first order neurons what we are discussing. As I told you, they carry sensory information about touch, proprioception from peripheral nerves to the medulla oblongata. Okay, so the origin, the first order neurons, they arise, they have two different names. Okay, one arising from the upper limb, that is above the level of T6, and the other is arising from below the level of T6, okay, from the lower limb. So the upper limb first order neurons, they travel in fasciculus cuneatus, okay, which relays in nucleus cuneatus, which is present a bit lateral. Okay, whereas the lower limb, that is below T6, are traveling in a fasciculi. Fasciculi is a bundle of neurons, the first order neurons. So this is fasciculus gracilis, okay, and it is present in the medial side, as you can see, and it relays in the nucleus gracilis. Okay, so these are the first order neurons which are carrying the proprioception, okay, the pressure, touch and all, okay, proprioception, vibration, and a normal touch, they are carrying like this. See this, they are going through these tracks, fasciculus cuneatus and fasciculus gracilis. Fasciculus cuneatus from the upper limb, fasciculus gracilis from the lower limb, and they relay in the medulla oblongata in the corresponding gracilis. Okay, nucleus gracilis and nucleus cuneatus. Done. So from here, where they're going, as you can see, so from here they travel up through the medial lemniscus. Okay, so they are traveling in the dorsal column of the spinal cord and also the medial lemniscus in the brainstem. So that's the reason we call it as a dorsal column medial lemniscal pathway, and they're crossing. So they do cross and they're reaching the postcentral gyrus where they relay sensory information. So let's see, we are done with the first order. Let us look at the second order. Second order, as I told you, it is starting with the peripheral nerves, and from there, with the help of fasciculus cuneatus and gracilis, it is reaching the nucleus of cuneatus and gracilis. Okay, so the second order neurons, they begin in the nucleus cuneatus and gracilis, and from here they deliver or they reach the thalamus. Okay, as you can see, here is the thalamus, and from here you can see the third neurons or third order neurons are taking origin. So these second order neurons within the medulla oblongata, they cross to other side of the CNS. They do cross and they travel in the contralateral medial lemniscus to reach the thalamus. And the third order neurons, they start from the thalamus, they reach ipsilateral, that is on the same side of the sensory cortex of the brain. Okay, and which part of the thalamus, which part of the, because in physiology they'll ask like what are the nucleus of thalamus, okay, what are the nucleus of hypo. So from the nucleus of thalamus they travel in PLN, that is posterolateral nucleus of the thalamus. Through the internal capsule they terminate in the sensory cortex. So let me revise the dorsal column lemniscus pathway again. The logic is simple. They are carrying position, that is proprioception, vibration and touch. Okay, and it goes through the spinal cord in the dorsal column, because we all know the dorsal side is sensory, the ventral side is motor in the spinal cord, and from here they reach the nucleus fasciculus and nucleus gracilis. Okay, nucleus cuneatus and nucleus gracilis, sorry. And from here second order neurons, they cross the medulla oblongata, they travel through the medial lemniscus, they relay in posterolateral nucleus, okay, of the thalamus. From there the third order neurons, they go to the ipsilateral sensory cortex. So this is what you need to know about the dorsal column medial lemniscus pathway. Let us look at the anterolateral system, which is important again. Okay, so the anterolateral system consists of two things. It's the common name is spinothalamic. So it travels in the spinal cord, from there it reaches the thalamic, so we call it as a spinothalamic tract. The same spinothalamic tract is divided into an anterior spinothalamic and also a lateral spinothalamic. Similar to dorsal column medial lemniscus pathway, it also has three neurons, a three order of neurons. Let's see each order. But what is the function of an anterior spinothalamic tract, which is traveling in the anterior part, and also a lateral spinothalamic tract, which is a bit lateral, okay, in the spinal cord, and these are a bit ventral. You can see they're ventrally placed. So what happens from here? First thing, these structures, the anterior spinothalamic tract, it carries crude touch and also the pressure. Okay, whereas the lateral spinothalamic tract, very important, it carries pain and temperature. Okay, so the same thing is depicted here. Pressure and deep touch are here carried in the dorsal column, and sorry, they're a part of the dorsal system, but in the medulla oblongata they lie a bit anteriorly, and through that they enter the medial lemniscus, the brainstem, medulla oblongata, and they're reaching the thalamus. But as you can see, there is another pathway for the pain and temperature. Yes, it is entering, but instead of crossing there, it is crossing pretty close to the central canal of the spinal cord. See this? And from here it is traveling onto the lateral aspect of the medulla oblongata, and it is going through the medial lemniscus. Logic is simple. So in the spinal cord, they are dorsal again. They are traveling through the medial lemniscus, but their naming is based on the position of these fibers in the medulla oblongata. If it is anterior, it is anterior spinal thalamic tract, which carries deep touch and pressure, and if it is lateral, it is lateral spinothalamic tract, very important, which carries pain and temperature. Because if you know this location, just focus. The anterior is crossing here, but the lateral is crossing very close to the central canal. Okay, so if you know this, you will understand why in syringomelia the lateral spinothalamic tracts are affected, and why and what happens in case of hemisection, that is Brown-Séquard syndrome. Just focus on this part. Okay, how they are crossing. Now let us look at the order of the neurons. The first order, similar to DCML pathway, they arise from sensory receptors in the periphery, and they enter the spinal cord, and they do not cross immediately. Okay, they ascend at about 1 or 2 vertebral levels. Okay, then the synapse at the tip of the dorsal horn. So this is the tip of a dorsal horn. Okay, we call this as substantia gelatinosa. Okay, this area of synapse is known as substantia gelatinosa. So from here in the what we call is a spinal ganglion, from here you will see the origin of the second order neurons. So the second order neurons, they carry information from this substantia gelatinosa, okay, to the thalamus. And after synapsing with the first order neurons, these fibers, they decussate within the spinal cord, and they form two distinct tracts. One is, as I told you, the crude touch and pressure fibers, which are a part of anterior spinothalamic tract, and also the pain and temperature fibers, which are actually entering the lateral spinothalamic tract. Okay, so though they are structurally dissimilar ones, but though they are functionally distinct in character, you can see they are going parallel to each other like a single pathway, and they end superiorly by synapsing in the thalamus. So the third order neurons in the thalamus, they carry signals from thalamus to the ipsilateral primary sensory cortex. Okay, as I told you, they form ventro-posto-lateral nucleus of the thalamus, VPL, concerned with the sensory system. So from there they travel through the internal capsule, and they're terminating in the sensory cortex. So we're done with the two important pathways. One is the spinothalamic tracts, that is the anterolateral system, and the other is dorsal column medial lemniscus pathway. Try to by heart all these things, very important, and draw this diagram. Next is spinocerebellar tracts. As we all know, we're done with the conscious ones, that is the tracts which are carrying the conscious sensations, that is DCML and anterolateral tracts like pain, touch and temperature. There are some structures which carry unconscious information, okay, and we call this as spinocerebellar tracts. So its logic is simple. From the spine, instead of entering the brainstem, they enter into the cerebellum. So these tracts are posterior spinocerebellar tract, anterior spinocerebellar tract, cuneo-cerebellar tract, okay, and also a rostral cerebellar tract. Okay, so let's see what are the sensations they carry. They transmit information from the muscles, okay, from the muscles, the position of the muscle, whether it is flexed or extended. So you need to carry a proprioceptive impulses from muscles on a constant basis. Okay, so the posterior spinocerebellar tract carries information from the lower limbs, okay, and even the anterior spinocerebellar tract also carries proprioception from the lower limbs. Okay, and the logic is both of these tracts, they terminate on the ipsilateral side, as you can see here. So the anterior and posterior, they are terminating on the ipsilateral side of the cerebellum. They are not crossing. Okay, next is the cuneo-cerebellar tract. Okay, it is cuneo, that means it's from the upper limbs, so it carries proprioceptive information from the upper limbs to the ipsilateral cerebellum. So there is also a rostral spinocerebellar tract which carries proprioceptive information from the upper limbs to the ipsilateral cerebellum. They're same. So what is the basic difference now you notice from the dorsal column lemniscus pathway, medial lemniscus pathway, and also anterolateral system? They cross, but the cerebellar tracts here, they do not cross. So this is the one important thing take home from you. And we have two things. One is the antero and posterior spinocerebellar tract which carries proprioception from the lower limb, and also cuneo and rostral spinocerebellar tracts which carry from the upper limb, and they do not cross. Okay, they do not cross, and they carry sensation of proprioception from the limbs to the ipsilateral cerebellum. So what happens? What happens if there is any lesions in these sensory pathways? We have a dorsal column medial lemniscus pathway defect, and we all know that it carries fine touch and proprioception. So in these lesions of DCML, we have loss of proprioception and also loss of fine touch. But as I told you, even anterolateral system, that too what we call anterior spinothalamic tract, it is carrying crude touch or deep touch. So there are some tactile fibers which are traveling in the anterolateral system. So that's the reason the patient is still able to perform some tactile functions. Okay, and if there is a lesion of DCML pathway in the spinal cord, the sensory loss will be ipsilateral, because the decussation of DCML occurs in the medulla oblongata. See this image. So where they are decussating? They are decussating in the medulla oblongata. But what is the problem with the spinothalamic tracts? Spinothalamic tracts, they cross in the spinal cord itself. Okay. So if the lesion of the DCML, if it occurs in the spinal cord, the loss will be ipsilateral because the crossing occurs in the medulla oblongata. But if the lesion occurs in the medulla oblongata, okay, after crossing, then the loss will be contralateral. And where do you see? Yes, there is a hemisection. You will see the ipsilateral loss of proprioception and fine touch. Whereas when it comes to other diseases like vitamin B12 deficiency and also syphilis, you can see damage to DCML, and the earliest sign will be loss of proprioception and vibration sensations. Okay, so this is DCML pathway defect. And next is injury to the anterolateral system. Okay, we all know anterolateral system, major is lateral, which carries pain and temperature. So any lesion will produce impairment of pain and temperature sensation in these. But logic is simple. If there is a damage, let us say if there is a damage here, what is happening if there is a damage? The damage is, sorry, I have to draw it like this. If there is a damage because of the crossing, you can see the loss is contralateral. Whereas if there is a damage here, the DCML loss is ipsilateral. So just remember this way, DCML ipsilateral, that is for spinal cord damage. Anterolateral system contralateral, that is damage to the spinal cord produces contralateral symptoms. So that's the reason the sensory loss in case of, that is pain and temperature loss in case of damage to the spinothalamic tracts will be contralateral, because the spinothalamic tracts decussate within the spinal cord. So you can understand this better by looking at this important syndrome called Brown-Séquard, which can be a potential question. Okay, they asked it once, the Brown-Séquard syndrome. So the Brown-Séquard syndrome refers to the hemisection or one-sided lesion of the spinal cord, and this can be due to traumatic injury. Okay, and when there is a hemisection, it involves both the systems, that is the anterolateral system and DCML pathway. In DCML pathway, what happens? There is an ipsilateral loss of touch, vibration and proprioception. If there is an anterolateral system damage, it is contralateral loss of pain and temperature sensation. Okay. In the same way, even the pyramidal tracts also the decussate, right? But the decussate in the medulla oblongata. So when there is dissection of the spinal cord, okay, so the descending motor tracts will lead to the ipsilateral hemiparesis on which side the lesion is occurring. Okay, it causes ipsilateral hemiparesis, ipsilateral loss of touch, vibration and proprioception, and contralateral loss of pain and temperature sensation. Okay, So that's the reason the medulla oblongata is paired here. Only spinal cord has a lesion leading to this kind of clinical picture. The same thing is depicted in the image. Please note this. So what happens in Brown-Séquard syndrome? Brown-Séquard syndrome is hemisection or complete removal of the half part of the spinal cord. So what is happening here? There is the contralateral loss of pain and temperature here, but ipsilateral loss of tactile sensation of proprioception and also ipsilateral hemiparesis because of the damage to the pyramidal tract. Okay, and one more clinical point can be syringomyelia. As I already told you, syringomyelia is the issue with the central canal. Okay, and it will there will be a broadening of the central canal and damaging the nearby nerves. And as you can clearly see, in the nearby area we have sensory system which is getting carried. So that's the reason in this lesion of syringomyelia there is involvement of the anterolateral system instead of DCML. You will see involvement of anterolateral system. So pain and temperature sensations are lost in case of syringomyelia. So that's it. So this is what you need to know about the ascending tracts. Okay. Hello everyone, Dr. Naveen here. So this video is an anatomy video and we will be covering the neuroanatomy topic, that is trigeminal nerve, that is fifth cranial nerve. In the cranial nerve part, these are the usual subheadings. Okay, one is the nuclei associated with cranial nerves, and the second is what are the functional columns which are associated with these cranial nerves, or we can call it as functional components. This is the second heading. And the third heading is connections, or we can say the distribution of this cranial nerve. So please, in the exam, in the theory exams, don't get confused. Look at what are the subheadings under each essay. Are they asking about nuclei? Are they asking about the functional components or columns? Are they asking about the connections or distribution? Nuclei is fine. Like for example, for fifth cranial nerve, we have 4 nuclei. One is motor nuclei, the other is sensory. The sensory part, we all know that trigeminal nerve is a mixed nerve. So sensory is divided into 3 entities. One is mesencephalic nuclei. Next is chief sensory nuclei, and we also have spinal nuclei. So when they're asking to describe nuclei, you have to describe the location of these nuclei and what are the connections or outputs they're giving out. When they say functional components, they are referring to the columns or components. So what are the common or usual columns or components which we see? We have motor columns and we also have sensory columns. So under motor columns we have the following subheadings. That is, when I say motor, it is efferent, right? So E is common, efferent. When I say sensory, afferent. A is common. Now you see, we have general somatic efferent. We have special visceral efferent. We have general visceral efferent. So these are the 3 motor columns which are present. I'm giving you a general details of all the cranial nerves. Then I'll come back to what are the functional columns or components specific to the trigeminal nerve. When I say sensory columns, we have general visceral afferent, special visceral afferent, general somatic afferent, and special somatic afferent. This is in general. Now, with regards to the trigeminal nerve, with regards to the cranial nerve 5, which is a mixed nerve, we have sensory and motor components. So you will have motor functional columns and also sensory functional columns. With regards to motor functional column comes from SVE, special visceral efferent. So from the special, it arises from the motor nucleus. motor nucleus of trigeminal nerve. So we have special visceral afferent. With regards to the sensory part, we have general somatic afferent, which gives rise to three of this nuclei, that is mesencephalic, chief sensory and spinal nuclei. So with this background knowledge, let's now start the topic of trigeminal nerve anatomy with nuclei. So what are all the nuclei we have? We have motor nucleus, we have sensory, and within sensory what we have? We have chief sensory, we have mesencephalic, and yes, we also have the other entity, that is spinal. These are sensory. Now, first we'll finish off the motor nucleus. So motor nucleus is under category of special visceral afferent. So now what do? They actually supply striated muscles arising from brachial arches. Okay, pharyngeal or brachial arches or branchial arches, they supply. So in this we have motor nucleus of the trigeminal nerve, and where it is situated? It is situated, I'm only depicting the sensory nuclei here. Okay, but again we also have a motor root. Okay, let me draw a diagram just to know where it is arising actually, so that way it gives you a clarity like where it is arising and all. So this is, so I'm drawing this diagram now. We have a motor column, okay, which is, I'm taking the red color here. This is the motor nuclei, and then let me take another color. Okay, let's take sensory column. So we have this, the whole sensory column here in blue. Okay, I'm just highlighting it in blue. Within this sensory column, we have three entities. One in black. This is mesencephalic nucleus, and the next is bigger one, chief sensory nucleus, and we have a smaller one again, which is many nuclei forming the spinal nucleus part. This is spinal nucleus. Let's look at the location. This nuclei, which is the motor nuclei of trigeminal nerve, on a single nuclei, where it is located? It is actually located upper part of pons. So this is located upper part of pons. So pons, these are all brainstem nuclei, right? They are located within the brainstem. Now, chief sensory nucleus of the trigeminal nerve, okay, it is again located in the upper part of pons. Okay, it is located in the upper part of pons in the dorsolateral region. It is lying lateral to the motor nucleus, immediately lateral to the motor nucleus, and it lies intermediate position between the mesencephalic nucleus and the spinal nucleus. It's as simple as that. Then what about spinal nucleus? It extends caudally. From the chief sensory nucleus. It is going down. Okay, it extends caudally from the chief sensory nucleus, starting from the pons. Okay, and it reaches up to C2 segment. That's the reason we call it a spinal. Even the second cervical spinal segment also contains the spinal tract of trigeminal nerve. Let me make a point here. Okay, it also contains the trigeminal part. Okay, now what are we left with? We also have another nucleus, that is the mesencephalic nucleus, which lies cranial or upper end of the chief sensory nucleus. It lies on top of it. Okay, it is in the region of pons and also midbrain. It is in the region of midbrain to pons. Okay, so because it is extending into the midbrain, we are calling it as mesencephalic nucleus. Okay, because it is extending into the midbrain, we are calling it as mesencephalic nucleus. So this diagram is very important. Draw a functional column, put 3 nuclei, middle is chief sensory, just medial to it we have motor nucleus. Now let's come back to the motor nucleus part again. So we're discussing that it supplies striated muscles, that to branchial arches, and you know its location. It is in the upper pons, just medial to the chief sensory nucleus of the trigeminal nerve. And their fibers, they give rise to the motor root of trigeminal nerve. And this motor root of trigeminal nerve, it arises, as you can see, this is the motor root of trigeminal nerve. It goes through the trigeminal ganglion and it arises where it is. It arises from the ventral aspect of the pons. Okay, it arises from the ventral aspect of the pons, and it crosses superior border of the petrous temporal bone, okay, and posterior to the trigeminal ganglion. It goes through foramen. It goes through foramen ovale. So the motor root of the trigeminal nerve passes through the foramen ovale and it joins the sensory root. Okay, it passes through the foramen ovale and it joins the sensory root. Now let's come back to the path of other nuclei. Okay, see again the paths and all, it's very tough to remember, but one thing is it is passing through the foramen ovale. Try to remember that. Next is chief sensory nucleus. We all know it comes under GSA, general somatic afferent column. Okay, we know that its location is in the upper part of the pons, lateral to the trigeminal motor nucleus, and it is mainly concerned with tactile sensitivity. Next is spinal nucleus. You know the location. It is in craniocaudal direction, complete craniocaudal direction, reaching up to the C2 segment. And most of the afferents from chief sensory and also the spinal, so most of the afferents, okay, they are from the trigeminal ganglia. Okay, after entering the pons, they divide into ascending and descending branches, as you can see here. Okay, after entering into the pons, they divide into ascending and descending branches, and the ascending fibers, they end in chief sensory nucleus. Descending fibers, they form spinal tract of the trigeminal nerve. So this is what you need to remember. And next, finally, we have the mesencephalic nucleus. And this mesencephalic nucleus, why it is mesencephalic? It is located in the midbrain. Okay, it is similar to dorsal root ganglia of spinal cord. It contains pseudo-unipolar cells. It contains pseudo-unipolar cells. Okay, and it is concerned with mainly the proprioception. We'll come back to it in detail, but these are the nucleus stuff which you need to write for 5 marks. Okay, this much is enough. Now you see all these nuclei, okay, they carry sensory sensations with the help of ophthalmic, maxillary and mandibular division. Okay, even mandibular nerve is also a mixed nerve. With the help of ophthalmic nerve, maxillary nerve, mandibular nerve, they relay in the trigeminal ganglion. From there, they reach mesencephalic nucleus, main sensory nucleus, and spinal nucleus. And where they go from there? Because they are afferents, they carry sensations, right? So when they carry sensations, they have to reach a path. So what is that path? These, what I say, from the mesencephalic nucleus, it travels through, please remember, dorsal trigeminal lemniscus, okay, and both main sensory and spinal nucleus, the afferents, they pass through ventral trigeminal lemniscus, and from here both they relay into ventro-posteromedial column of the thalamus, which is concerned with sensory system, VPM of the thalamus. From there they reach sensory cortex. So this is the pathway. So starting from the facial stuff, from there they are getting into the trigeminal ganglia, from them into the nucleus which is present in the brainstem, and from there with the help of dorsal and ventral trigeminal lemniscus through the ventro-posteromedial area of the thalamus, and from there they are reaching the sensory cortex. Please remember this. Okay, this is very, very, very important, this part. Now we are done with the nuclei. Okay, we are done with the functional columns associated with it. Now let's try to look in detail the functional columns and what are the areas they are actually supplying. Okay, We'll start with the special viscerant efferent column, that is the motor root. So motor root, as I said, they supply pharyngeal arches, right? So they supply muscles of mastication. Please remember what is their distribution. Like they get into these muscles of mastication, and they also reach tensor tympani, and tensor pallati, and we have anterior belly of digastric, okay, and mylohyoid. So what are all the striated muscles which are supplied by the motor root of trigeminal nerve? So these are all the nerves, okay. You can see here tensor tympani, tensor pallati, it's supplying the medial pterygoid muscle and all, okay. It is this is how they supply, okay. Next, what about, we're done with the motor part. What about GSA, somatic afferents? Like what kind of sensations they are carrying actually? So this chief sensory nucleus and also the spinal nucleus, they are mainly concerned with exteroceptive sensations, like from skin and face, okay. Skin and face, they carry exteroceptive, like pain, temperature, okay, general touch and all. Whereas mesencephalic nucleus is expertise in carrying proprioceptive sensations. Proprioceptive, exteroceptive. So these proprioceptive sensations are carried from the muscles of mastication, temporomandibular joint, teeth and tongue. Like whether tongue is protruded or extruded, temporomandibular joint, whether it is protruded or extracted. So these kind of sensations are carried with the help of the mesencephalic nucleus. Okay, mesencephalic nucleus. Now, what are the divisions of the trigeminal nerve? We have three divisions. One is ophthalmic division, and you know the area which is supplying. Try to draw the diagram. So this is ophthalmic division. Ophthalmic division is only sensory and it contains GSA fibers only, functional components. Next is we have maxillary division. Maxillary division itself is sensory again. So it only carries GSC fibers. As you can see, this is the maxillary division. Whereas next is the mandibular division. Mandibular division is both sensory and mixed. That's the reason it contains both functional columns, GSA and also SV. So this is the division part, the distribution, the muscles supplied and everything. Okay. So now divisions and etc. is done. Distribution part, we did discuss motor part. Sensory distribution is also there here. As you can see, it is going through masseter nerve, deep temporal nerves. It is giving rise to buccal nerve. It is giving rise to nerve to lateral pterygoid, and it is also giving rise to lingual nerve. Okay, and through the ciliary ganglion, it is also giving rise to auriculotemporal nerve, which is involved. Damage to auriculotemporal nerve of trigeminal nerve or cranial nerve 5 leads to Frei's syndrome, okay, which is the recent question. It is giving rise to chorda tympani, inferior alveolar, mylohyoid, nerve to mylohyoid muscle, all these things. So general discussion is done overall, how to remember what are all the divisions. Let's get into the specifics with the help of the text which is given here. Now, you know all the ophthalmic, maxillary and mandibular from the trigeminal ganglia. You know we have a large sensory and small medial motor root. They run over the petrous temporal bone and they enter middle cranial fossa. Now, with specific to each cranial nerve, let's look at distribution. Ophthalmic nerve runs forwards in the lateral wall of cavernous sinus and it divides into three branches. Lacrimal nerve, frontal nerve, nasociliary nerve. Please remember this. What are the three branches of the ophthalmic nerve? Or I'll say V1 or Phi 1. These are lacrimal, frontal and nasociliary. So they supply the eyeball part, which in the image I have given you overall, but I'm getting into more specific now. Conjunctiva, upper part of nasal cavity. Let me highlight here only. Lacrimal glands, skin of the forehead and external nose and eyelids. All these parts are supplied by the ophthalmic nerve and ophthalmic. It contains three branches again. Lacrimal, frontal and nasociliary. Next is the maxillary nerve again. Maxillary nerve, as I said, motor trigeminal passes through foramen ovale. Maxillary nerve or V2, it passes through foramen rotundum. See, structures passing through the foramina of skull is very important for PG point of view. Okay, even for theory exams, you need to mention that maxillary nerve, it leaves the skull through foramen rotundum, and it enters the pterygopalatine fossa, and it goes through orbit of the eye into the inferior orbital fissure. Okay, and there it is called as infraorbital nerve. And this intraorbital nerve, it exits through the infraorbital foramen and it comes onto the face. Okay, so it is in the middle cranial fossa, it is in the pterygopalatine fossa, it is in the orbit, and it is coming onto the face. There are 4 regions into which you have maxillary nerve. So what are the branches of the maxillary nerve? Very important, it gives meningeal branch in the middle cranial fossa. It also gives ganglionic branches to the pterygopalatine ganglion. It gives a branch called zygomatic nerve. Okay, it gives a branch called zygomatic nerve. And it also forms posterior superior alveolar nerve, middle superior alveolar nerve in the orbit, and it also gives palpebral, lateral, nasal and labial branches within the face, and through these branches it supplies this following area. So let me read out what is that area which I just highlighted: nasal cavity, palate, upper teeth and gums, and skin of the middle third of the face. And it is also providing sensory supply to the maxillary sinus. And finally, it also has secretomotor fibers which are given to the lacrimal gland. Now, trigeminal nerve anatomy. Now we are coming into the V3, the biggest nerve, the mandibular nerve or mixed nerve, and it passes through foramen ovale, as I already told you. Okay, cranial nerve V3 or 5-3 passes through the foramen ovale, and it doesn't enter into pterygopalatine. It enters into infratemporal fossa, and now. Motor route plus sensory route, they pass deep to the trigeminal ganglia and leave the skull through mandibular foramen, and the trunk, it gives rise to the following branches: meningeal branch, nerve to medial pterygoid, mesenteric nerve, deep temporal nerve, lateral pterygoid, buccal nerve, auriculotemporal nerve, lingual nerve, inferior alveolar nerve, all these branches. So they supply muscles of mastication like temporalis, masseter, medial and lateral pterygoids, and also all these things we already discussed. But whatever the sensory supply here, ear, temporal region, skin of the lower 1/3 of the face, except the angle of mandible, because angle of mandible is C1. Okay, so this is the area which is supplied by the mandibular. And sensory motor part, you know, the first branchial arch derivatives. Okay, so this is the trigeminal nerve anatomy, and discussion of anatomy is incomplete without discussing clinical anatomy. Nowadays clinical aspects are given more importance or priority. We have 2 things. First thing, very important thing is, when I say trigeminal nerve, from medicine aspect we have headache, that is trigeminal neuralgia, very painful condition. It is, you will see paroxysmal attacks, okay, sudden attacks which come and go. There will be severe pain, okay, which is sudden and short duration, and it is in the areas of V2 and V3. Okay, among the 3 subdivisions, maxillary and mandibular nerve areas are involved. There will be sudden pain. Okay, so this is trigeminal neuralgia. What happens with lesions of the trigeminal nerve? Yes, it carries facial sensations, right? So there will be loss of general sensation, and also very important key point is there is loss of corneal reflex. Okay, and motor loss leads to flaccid paralysis of the muscles of mastication, and again it is supplying tensor tympani which dampens the sound, so you will have hypoacusis, partial deafness to low pitched sounds. So these are the 4 characteristic presentations or clinical features associated with lesions of the trigeminal nerve. So we were able to discuss in detail the subdivisions or branches, and you know how to approach nuclei, functional columns or divisions, distribution, connections, right, and branches, and also the clinical anatomy of the very important nerve, that is trigeminal nerve. Hi doctor, in this video I'll be discussing about the course and distribution of the trochlear nerve, that is the 4th cranial nerve, and the location of the trochlear nucleus. Along with that, we'll conclude our discussion by discussing the clinical significance of trochlear nerve paralysis. To begin with, when I say trochlear nerve, the other name is pathetic nerve, and it is 4th in order, that is the 4th cranial nerve. It is general somatic efferent. So it is only motor, it contains only motor fibers, that too general somatic efferent fibers, and it supplies only one muscle, that is superior oblique muscle, which is one of the extraocular muscles of eye. The origin of this cranial nerve is from the fourth nucleus, that is trochlear nucleus. What is the location of this trochlear nucleus? It is located in midbrain. So this structure is midbrain. It is located in midbrain at the level of inferior colliculus. Let us look at the origin and distribution of the cranial nerve 4 with the help of a flow chart. As we already discussed, the origin is from the trochlear nucleus, and in the trochlear nucleus it is located in the midbrain at the level of the inferior colliculus, and it takes origin from the dorsal aspect of the midbrain. It is a unique feature. All the cranial nerves, they take origin from the ventral aspect of the midbrain. The exception is trochlear nerve nucleus or trochlear nerve, which takes origin from the dorsal aspect. After the origin, the nerve encircles anteriorly around the brainstem and it runs forward towards the eye because it is supplying the extraocular muscle of the eye, that is superior oblique, and it runs in the subarachnoid space. So through its journey, it passes through the cavernous sinus, very important. So it's a dural venous sinus located in the skull. It is cavernous sinus, and which part of the cavernous sinus is the trochlear nerve associated? It travels on the lateral wall. The contents of the cavernous sinus are very important. Here I won't be discussing them, but the most important thing is the trochlear nerve or fourth cranial nerve, it runs on the lateral wall of the cavernous sinus. And as I already told you, it supplies the superior oblique muscle and it enters the orbit through an important fissure known as superior orbital fissure. So what are the key features from this flow chart? The origin is on the dorsal, it's a unique feature. It travels through the subarachnoid space inside the cavernous sinus on the lateral wall, and very important thing is it enters the orbit through superior orbital fissure. The same thing is depicted in a diagram here. You can see midbrain, this is the ventral part and this is the dorsal part. On the dorsal part we have superior colliculus and inferior colliculus, and it is located near to the inferior colliculus. So this is the nucleus of the fourth trochlear nerve. It is traveling, it is circling around anteriorly to reach the ventral part, and it is traveling in the cavernous sinus and the lateral wall. It is entering into the orbit through the superior orbital fissure. And what is that muscle it is supplying? It is superior oblique muscle. Let's look into the unique features of the cranial nerve 4. First and foremost, it is the smallest nerve in terms of the number of axons it contains. So it contains minimal number of axons. So that is the reason we call it as the smallest nerve. And it has the greatest intracranial length. As we all know, it is arising from the dorsal aspect, and when it wants to come forward, it has to circle around the brainstem. So this is giving it a characteristic property called the greatest intracranial length. Next is, it is the only cranial nerve that exits from the dorsal, that is rear aspect of the brainstem. And fourth very important unique feature is, it innervates the superior oblique muscle on the opposite side from its nucleus. All the extraocular muscles, you take superior rectus, inferior oblique. We also have medial rectus and lateral rectus. So these four recti muscles and the inferior oblique muscle, they get supply from the oculomotor nerve and also the abducens nerve. They get supply on the same side from its nucleus. Exception is the superior oblique muscle. It is getting supply from the opposite side. So what is the clinical significance of this fourth and important point here? Let me give you the clinical pearl here. Trochlear nerve, it decussates within the brainstem. So because of this decussation, when it is coming out of the brainstem, this is the midbrain part of the brainstem, the trochlear nerve, it is decussating. So this is the reason. If this is the right trochlear nucleus, it is supplying the left superior oblique, and if it is the left trochlear nucleus, it is supplying the right superior oblique muscle. So this is what happens because of the decussation. A key point here is, if the injury is occurring to the trochlear nucleus or the trochlear nerve before emerging from the midbrain or brainstem, this leads to contralateral superior oblique palsy. Okay, please, SOB is not shortness of breath, it is superior oblique. Similarly, if the trochlear nerve injury is occurring after the exit from the brainstem or after the decussation, this leads to ipsilateral SOB palsy. What is the main function of the superior oblique muscle? Why it is important to discuss the function of superior oblique muscle? Because when you know the function of the superior oblique muscle, you will know what happens with trochlear nerve palsy. So the trochlear nerve palsy or pathetic nerve palsy or the fourth cranial nerve palsy, what it leads to? It leads to paralysis or non-functioning of the superior oblique muscle. What is the function of superior oblique muscle? It depresses the eyeball and it causes intorsion of the eyeball. So the function depends upon its location. Let me give you pictorial example here. See, this is the eye and this is the nasal side. SOB causes depression and it causes intorsion. When SOB fails, what happens? Eye cannot look down because depression of the eye is lost. And in a resting position, what happens? Because it is unable to depress, the superior rectus and inferior oblique are functioning here. And what is the function of the superior rectus? It elevates the eye. So because they are functioning and because SOB is not functioning, they cause elevation of the eye. And at resting position, if you compare both the eyes, on the affected side, the eyeball is slightly elevated in the resting condition, and this is known as hypertropia. So what do you see in a case of trochlear nerve palsy? Because of SOB paralysis, the eye in resting condition will have an anomaly called hypertropia. Because of this, whenever patient tries to look down, let's take an example. He's trying to walk down the stairs, right? So when he is trying to walk down the stairs, he should look down. But on the affected side, what happens? The eyeball cannot depress. So this leads to development of vertical diplopia. So what is the presentation of cranial nerve palsy? It causes vertical diplopia. Very important. One functioning is depression. And now, by now, with the discussion, you know what happens if depression fails. Another function is intorsion. Failure of intorsion leads to a condition called X-cyclotorsion. Usually, this X-cyclotorsion is seldom noticed in patients. Okay, they only complain of vertical diplopia. But if you want to diagnose this condition, we perform a test called head tilt test. So they may ask an MCQ. Head tilt test helps in diagnosis of fourth nerve or trochlear nerve palsy. Let's look into the details of intorsion and what happens if intorsion fails and what is this X-cyclotorsion. Look at this image. This is what happens in a normal eye. It's a normal patient. This is right side of the patient and this is left side of the patient. Patient is trying to shift or tilt the head to the left side. Whenever patient tries to do so, the eyes are tilting to the opposite side. See, when she's tilting her head to the left side, eyes are tilting to the right side. So in this, what is happening? If this is the right eye is undergoing extorsion or X-cyclotorsion. whereas left eye is undergoing intorsion. So in a normal eye, my statement to you is, it is complex, but you should understand, when the head tilts to the left side, both the eyes rotate in the opposite direction, and in this what happens, the right eye is extorting and the left eye is entorting. So this is head tilt test. What happens if there is an abnormality? In a cranial nerve 4th palsy, at resting condition, because intorsion fails, this patient is having right 4th nerve palsy. This is the prerequisite condition. We are discussing the right sided 4th nerve palsy. Because of the failure of the intorsion, as I already told you, at resting condition, you will slightly see the extorted right eye. We call this as excyclotorsion. Normally in a paralysis patient, you will not see excyclotorsion because the patient tries to correct this condition. How he is trying to correct it, you see now. Right eye is extorted and slightly elevated. This leads to double vision. We know this point. To compensate, the patient is tilting her head to the opposite side of the paralysis. And when she does that, what happens? The left eye undergoes intorsion so that the visual field is adjusted, and because of the adjustment of the visual field, the patient can see the images better, and this vertical diplopia or torsional diplopia, we call this condition as torsional diplopia, is gone because of this tilt. So what happens in a trochlear nerve palsy patient? When you see a patient, the patient will complain of diplopia, and the two kinds of diplopia seen in 4th nerve palsy are, one is vertical diplopia. Why does vertical diplopia occurs? Because of failure of depression. And also torsional diplopia. Why it occurs? Because of failure of intorsion. And how does the patient is compensating this? The compensation occurs by, one is patient tucks the chin in. So patient tries to tuck the chin inside so that he can better see the down part of the visual field. So try to tuck your chin inside. What happens when you tuck your chin? Even though the eyes are not depressing, you can better see a visual field on the ground side. So this is what the compensation happens when there is hypertropia. How does excyclotorsion is compensated? As we already told you, head tilts to the opposite side. So tucking of the chin inside, tilting of the head to the opposite side is the compensation. So this compensation gives the patient a classic look called pathetic appearance. Because of this compensation, patient's face looks pathetic. So this pathetic appearance gives the name pathetic nerve or pathetic nerve palsy. So this concludes our discussion on the course and distribution of the trochlear nerve, the trochlear nucleus location, clinical significance of the 4th cranial nerve.